Madam, please start.
Okay, thank you so much. So, very good evening to all the respected office bearers, faculty, and delegates who have joined today for this Maha IIP program. And on behalf of Maha IIP, I welcome all of you to this very interesting session titled Pictorial Pediatrics Unveiling Health Through Pictorial Diagnosis. This is the first session of the year 2024. I would now like to request our Maha IIP President, Dr. Ram Gopal Chejara sir, and I would like to request him to say a few words to inaugurate this session.
Good evening, friends. Respected Basavaraja sir, President CIP 2024. Then Dr. Parmanand, Joint Secretary CIP. Nitin Shah sir, our Dr. Jitendra Gawane, our EB MMR region. Welcome all. We are starting a new concept in MyIP platform, that is a pictorial pediatrics, learning from the pictures or X-ray. It is an example. Now, this is the first episode, and it will be a theme-based program. Now, today we have kept a theme of neonatology, and our esteemed faculties are Dr. Rishikesh Thakre. He is a senior neonatologist. He doesn't require any introduction. And the second part is a pediatric surgery. And I welcome Dr. Ravi Ramdwar sir. He is a senior pediatric surgeon from Mumbai. So over to Amruta, and we will start the program as early as possible.
Sure, sir. Thank you so much, sir. I would request Maha IIP Secretary, Dr. Amol Pawar sir, to say a few words.
Thank you, Dr. Amruta. Welcome all the dignitaries, Basavaraja sir, Nitin, Renu ma'am, and core committee members of this Pictorial Pediatrics, Dr. Sushma Sahay ma'am, Vikas More sir, and Renu ma'am also. So this is a new conceptualized by Dr. Bhavesh Mithia sir, Pictorial Pediatrics. So it will come up with all the subspecialties in coming sessions. So without wasting time, I hand over back to Dr. Amruta ma'am.
Thank you, Dr. Amol. I would now like to request our scientific convener of Maha IIP, Dr. Bhavesh Mithia sir, to guide us regarding this session. Sir, over to you.
Good evening all. I'm actually driving and I won't be able to switch on my video, but we will start the program as early as possible. And this is a new concept, and I hope we all will learn and enjoy this program. Over to you, Dr. Amruta.
Thank you, Dr. Bhavesh Mithia sir. We have with us our National President, Dr. Basavaraja sir. Sir, welcome to this program. So I would like to request you to say a few words before we start the session.
Thank you very much, Amruta. Respected President of Maha IIP, Ram Gopal Chejara ji, and Dr. our mitochondria of Indian Academy of Pediatrics, who has made a big name at state, now is making a name at national level, Dr. Amol Pawar, and team Maha IIP. Maharashtra IIP is always known to come out with a lot of creative ideas. This is one of the unique program in the country where Maha IIP is starting this program. With a pictorial, one picture can speak thousands of words. That's what our traditional thinking. I'm sure Bhavesh Mithya, who has been thought about this program and coming out with a subspecialty thing, as also it is a creative. Our Nitin Shah sir is one of our always, we call him as a president of presidents. So he is always not only the president, he is always encouraging the youngsters, mentoring and guiding. Sir is there well in time and encouraging all the juniors. That shows that how much sir is committed and guiding and all of us. He is not only the guiding the Maharashtra, he is guiding across the India. Thank you, Dr. Nitin Shah sir, our president of president, joining here, and our executive board member, Dr. Jitendra Gawane is there, our dynamic joint secretary admin, Dr. Dr. our Parmanand Anandkar, my good friend, is also joined. So thank you all and wish you all the best for this program. So I'm sure with Rishikesh Thakre's experience, it is going to be appreciated not only by Maharashtra, across India. All this program is going to be a more successful thing. Wish you all the best for the program. Sushma Saina madam is there. Renu, our executive board member is here. Gravita. So Satish Sahane. Yesterday they are all there in our Mumbai office. Thank you all for supporting our IAP's work.
Thank you so much, sir, for those good wishes. I would now quickly request Dr. Parmanand, sir, Joint Secretary Admin, Central IAP, to say a few words.
Unmute, Parmanand, unmute.
Am I audible?
Yeah.
Yes, sir.
Good evening, everyone. It's nice to see Dr. Basavaraja sir, the National President, Nitin Shah sir, as Basavaraja said, President of Presidents, and the brainchild of the MAHA-AP, like, and the convener of the scientific program, Bhavesh Mithya, and Amol Pawar, and my friend Shezara. It's nice to see that very innovative idea of pictorial uh, pediatrics, which has been designed by the MAHA-AP team. And as Basavaraja says, it's when we have to learn, we take a lectures, we hear the lectures, but how much we retain, by just listening to a lecture is just 10% or maybe less. But when we look at the pictorial part of the same explanation and it will explain, the percentage of retaining the same content will be more. And that's actually the thought process behind have a pictorial pediatrics, and we can many more diagnose, or we can learn many things on this concept. And to execute this, we have none other than a great, my friend Rishikesh Thakre, and great neonatologist from Aurangabad. And we all have learned neonatology from here in Maharashtra for so many years. And same thing will say with Ravi Ramadwar sir, is that the one of the topmost pediatric surgeon in the country, and with his experience about the pediatric surgery and different things, we will able to he will guide us through multiple X-rays or multiple case scenarios on a pictorial way, which will help all of us to diagnose the surgical conditions early, and which will help us to treat them on time. With this few words, I thank MAHA-AP, and wish all the best to Dr. Ram Gopal, Amol Pawar, and the team. And I also welcome here Renu Madam, Jitendra Gawane, and Satish Shane be here, and Sushma. And I back to Amruta and thanks for giving this opportunity to be here. Thank you so much.
Amruta, 1 second. Okay.
Yes, sir.
Before starting, I would request Dr. Nitin Shah sir to sum up the program and give the take-home message at the end. So, sir, it is your responsibility to go through the full program and give the take-home message at the end.
I will try.
Yeah. Thank you, sir.
Okay.
Thank you, sir. So we shall now begin with the scientific session. Our first talk is by Dr. Rishikesh Thakre, sir, on pictorial pediatrics in neonatology. May I request the CV slide, please? So Dr. Rishikesh Thakre, sir needs no introduction actually. Sir is a very senior neonatal consultant and director at Neo Clinic and Hospital. Dr. Thakre, sir is extensively involved in training of UGs, PGs, fellows, nurses, and practicing fellow pediatricians. And his passion for neonatology is evident through his many publications, books, paper presentations, talks, and at various national and international forums. So over to you now, sir, for the first session on pictorial pediatrics in neonatology.
Okay. So, is the screen visible?
Yes, sir.
Yeah, okay. Thank you so much. Very good evening to you all. It's indeed a pleasure and privilege to be part of today's proceedings. And my sincere thanks and gratitude to the MAHA-AP team led by Dr. Ram, and so also Dr. Bhavesh for giving this topic on pictorial cues in neonatology. So let me walk through these case studies as they come through to you in your busy OPD. And I think most of the times you would be able to come to an easy conclusion. So here we go. So have a look at this baby. This baby had come for vaccination, and obviously something is very startling on this baby. Those of you who have made a clinical diagnosis, I would say you belong to the older generation of pediatricians. And those of you who didn't make this diagnosis, I would congratulate them. Simply because in today's era, this should never ever be a clinical diagnosis. Once a clinical manifestation comes in, you have missed the boat, for irreversible brain damage has set in. So this always has to be a biochemical diagnosis. And obviously, what is staring here is a baby with congenital hypothyroidism, and everything that you would want is there, which would be diagnostic for this baby. The question is, what would you prefer as screening for this baby? Cord blood or day 2 or 3 screening, either of that is okay. But mind you, if it's a preterm or a low birth weight baby, preferably opt for day 2 or day 3 screening, simply because you would otherwise pick up that elevated TSH surge, which is falsely there in the cord blood for preterms and low birth weights. When it comes to low birth weights and sick babies, especially those admitted to the nurseries, you would wait at least for day 5 to day 7 when you would be able to get the true reading for these babies. Mind you, as per the recommendations, the unit for reporting for thyroid profile preferably should be checked, simply because the values would change. If you have a baby with a TSH on screening more than 20, you would recall this baby and do a repeat TSH. But if you have a baby with a TSH which is high, you would immediately perform serum TSH and free T4. Once you have a TSH and a low T4, the values to be interpreted are based on the age. So less than 2 weeks, any value more than 20 is pathological, which would indicate that you would start specific therapy, that is thyroxine supplementation. And if the TSH beyond 2 weeks is more than 10, then only you would start this baby on thyroid supplements. A point to be noted is a metabolic screen is not an indication for starting therapy. You must confirm by doing TSH and T4. And obviously you would follow up with TSH. Okay. So have a look at these babies. What you have here is a vascular lesion, and I think the diagnosis is very obvious. And I would want you also to have a look at these 2 other babies. Now, anybody will say that this is an hemangioma. Now, the point is it a congenital or an infantile hemangioma? Simply because something which is present at birth, we would label it as a congenital hemangioma, versus something which appears after birth in the first few weeks thereafter, you would label it as infantile hemangioma. Why is it equally important to know the time of appearance? Congenital hemangiomas don't follow the rule of proliferation, involution, and disappearance, versus infantile hemangiomas which follow that rule. Infantile hemangiomas, if requiring treatment, are amenable to drug therapy, which is not so when it comes to congenital hemangiomas. If you have a congenital hemangioma, you are further going to ask, is it rich or is it niche? What does it mean? Is it rapidly involuting congenital hemangioma, or is it a non-involuting congenital hemangioma? Simply because this will help in terms of prognosis. Versus a third category of lesions which are present at birth. For example, have a look at this baby. You have this lesion which was there noticed at birth, and there was some discoloration which was noticed, but more importantly, it was a soft cystic baggy swelling. And whenever you have any swelling, you auscultate. You find that this baby had a murmur. So what we had here was a vascular malformation, which was confirmed in an ultrasound and thereafter on an MRI, which requires a totally different form of therapy. So this is a vascular malformation. Question is, which of these 3 lesions would you treat? You would not treat the lesion based on the size. You would treat if it is life-threatening or is coming in the way of the function. So amongst these 3 lesions that we have, you would treat the one near the eye because it's going to be progressive, because we said infantile hemangiomas are going to increase in size over first few months to years. And this is where there will be obstruction to the vision. So the drug of choice here would be propranolol. Versus this baby, or for that matter, the other baby, they are not the ones which are going to merit treatment simply because they are not going to cause any disturbance in structure, function, or are life-threatening. The vascular one would be the one which would require a surgical management. Okay, have a look at this baby. The diagnosis is again very clear. It's a preauricular attack. Question is, would you screen for hearing for these babies? Definitely yes. Would you screen for renal ultrasound? The answer is no. There is no role today to routinely screen for renal ultrasound unless there are associated two or more minor anomalies or one major anomaly. Then only you would do a renal ultrasound, not otherwise. So what would you do? Reassure the parents. That's all that is required. Have a look at these two babies. Both of them have hypopigmented patches. Both of them are macular. Both of them are present since birth. One on both of these are ominous for their predicting something in the future which is going to go haywire. So the question is, what is this patch? So this is like a leaf. So we will call it as an ash leaf. Mind you, an isolated ash leaf macule has no value simply because a healthy population up to 2 to 3% would have this lesion. But when it is associated with a Chagrin's patch, it will be a marker for development of tumors later on, affecting different organs of the body, and is a predictor for uh, 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 neurocutaneous disorder. Versus this, where you have a speckled appearance of hypopigmentation, which follow the lines of Blaschko. What is it? This is hypomelanosis of Ito. Why is it important to diagnose? It is simply because these children would need a structured long-term neurological follow-up simply because they would end with motor delay, cognitive delay, epilepsy, and therefore they are the ones which require intensive counseling and follow-up. Now, bread and butter problem for you is jaundice in the OPD. Question is, which of the babies with jaundice are having pathological jaundice in your first assessment? So we do know that physiological jaundice is a diagnosis of exclusion. Question is, can I pick a pathological jaundice in my first assessment, which is clinical? Obviously, yes. If you have a sick baby with jaundice, it is always pathological. If you have a jaundice which is seen in a preterm baby, don't take it as physiological unless proved otherwise. Any jaundice associated with poor feeding or feature suggestive of decreased feeding on history, again, is grossly abnormal. And most importantly, every baby of jaundice must be interpreted with the weight, simply because any weight loss more than 10% will tell you that this is non-physiological jaundice, and this is dehydration, which is secondary to inadequate breast milk, what is called as breast feeding jaundice, which is an early onset jaundice, which is the commonest cause today of jaundice that you and me would be seeing. And lastly, no baby with jaundice should have a color of the urine or stool not being looked at simply because a high colored urine staining the diaper or a clay colored stool would suggest a conjugated hyperbilirubinemia. And obviously, any baby with onset of jaundice within the first 24 hours or extending beyond 14 days of life would be taken as pathological unless proved otherwise. Time and again, you would have a mother which would pinpoint to you to say, what is it? And obviously, this is a sacral dimple, normal or abnormal. Simply because you pronounce it as normal, and you may end up with a major deficit which would have been otherwise gone unnoticed. So how do you know that is normal or abnormal finding? Simply because many of the babies would have these, but any of these sacral dimples, which are more than 0.5 centimeters in size, beyond 2.5 centimeters circumference, and those which are associated with tuft of hairs, discoloration, or where there is associated neurocutaneous deficit, those are all suggesting that it is pathological, and you would want to do neuroimaging. The choice here is to do an ultrasound for screening, but there may be a neural tube defect which will be noticed, and definitive test that would be required prior to doing a surgery for this baby is to ask for the MRI spine. But the screen tool here is ultrasound of the spine. So look for these clinical clues which tell you that this is a pathological sacral dimple. Not all of them would need evaluation otherwise. Have a look at this baby. Okay, and have a look at this baby. Yeah, both the babies have something very common, asymmetry of the faces. The thing that is going to give you a clue to the diagnosis here is to look at whether the forehead is involved, the eyelids are involved, and the furrow is involved. So in this baby, there are no wrinkles over the forehead, the eye remains open, so the eyelid is involved and the furrow is gone. So this is a facial palsy. So this is left lower motor neuron facial palsy. The commonest cause is a forceps delivery. Versus this baby, where you find that there is right side which is involved. There is no involvement of the forehead, eyes, or the furrow. There is only deviation of the face or the mouth, and therefore this is absent depressor anguli oris, which is something which is there since birth. And usually these babies, between the two, which of these would be requiring a screening for possibility of an underlying congenital anomaly? Always, before you give assurance, which will happen for these babies with facial palsy, for all such babies about with absent depressor oculi muscle, they 30 to 40% of them would have an associated underlying genitourinary or a cardiac anomaly, and therefore it is worthwhile screening for these babies. This baby with this lesion, what is the diagnosis? The diagnosis is staring at you. What you have here is what is called as a blueberry muffin rash. And whenever you see a blueberry muffin rash, you must say, is it neoplastic or non-neoplastic? A neoplastic infiltration in the form of a malignancy or a non-malignant condition mimicking this is what we need to look at, or at times it suggests there is an extramedullary hemopiosis, and the clue here further to the diagnosis is based on whether there is associated anemia or infection. Another baby, these babies come to you at around 2 weeks of life. This is a very unique congenital infection because that's a clue, but the lesion is vesicular, there is associated erythema, and the disease may be restricted to the skin, eye, and mouth, or it may be restricted in addition to the brain, or it may be disseminated. What you have here is a classical herpes simplex virus infection. How do you confirm? By doing a PCR or electron microscopy. A Zank smear is not a sensitive test to pick up HS infection. What would you screen? Such babies must be screened for eye and brain simply because many of them would have associated lesions, either which may be present at the time of diagnosis or may appear sometimes down the line. Would you breastfeed this baby? Yes, the baby can be safely breastfed. But the most important is how long to treat. If it is something which is restricted to skin, eyes, and mouth, you would give acyclovir for 14 days. But if it is something which is disseminated or with neurological manifestation, give it for 3 weeks. But more important is you would give an extended therapy, which is meant for suppression of the viral replication of at least 6 months. And these are one of the few indications where you would give chronic therapy to a newborn. So that's how herpes simplex can be diagnosed. These babies come to you in bulks, they come in epidemics. They come to you with fever, day 3, day 4, decreased activity, feeding, and you find this is a classical lesion which is seen with perinasal hyperpigmentation or perioral hypertension. You pick up the baby cries a lot. So this is a baby which shows you paradoxical cry. The diagnosis is given to you here by the mother. You would treat it as sepsis unless proved otherwise, simply because there will be leukopenia, marked leukocytosis, or there may be thrombocytopenia. What you are looking here is nothing but congenital chikungunya, and this is something which has a very classical facial appearance, one of the few lesions where you look at the baby and you can make a diagnosis. The diagnosis is confirmed by doing a PCR or doing IgM, anti-chickpea antibodies. The treatment is all supportive, but ask for the mother how she is, and she will give you an history of either suffering or having suffered in the last 1 week or so with similar kind of infection. Whenever you see any X-ray in your busy OPD, obviously what is striking to you here is coiling of the tube, and you have made a diagnosis of tracheoesophageal fistula. But I have said what two lesions are seen, simply because if you have seen one lesion, hunt for another lesion unless proved otherwise. So what you have here again is a second lesion. So imagine you have a tracheoesophageal fistula, and then you would screen this baby with an ultrasound, which confirms your clinical suspicion that there is associated duodenal atresia also. So two lesions in the same baby. What would you order for this baby? Obviously, you would order for is karyotyping. We have a very high probability that this would turn out to be trisomy 21. The message was, next time you see a congenital anomaly, look for other anomalies, and unless proved otherwise, all major anomalies up to 30 to 40% of the times would have an underlying cardiac, renal, genitourinary, or you have a gastrointestinal lesion, and then it becomes very difficult to justify to the parents, how did we miss this anomaly when it was present at birth? All three babies have same diagnosis, that is, it is congenital in origin. So it's a congenital infection. All three are showing you on the CT calcification. But there is a characteristic calcification that is seen here, which is pathognomic, or which should lead you to say you would do a screening for these disorders. What you have here is periventricular calcification. What you have here is diffuse intracranial calcification, but with microcephaly. And what you have here is basal ganglia calcification. And which are these three congenital infections which would come with these, though the differential diagnosis for either of these calcifications is quite big, is that when you have a periventricular calcification, please rule out a congenital CMV. Microcephaly with diffuse intracerebral calcification is a congenital Zika virus infection, and basal ganglia calcification is congenital HIV, and that is how you would look at these. And this baby came with acidotic breathing, there was stupor, there was tonic posturing. What is characteristically seen here is loss of hair. So you would not see a newborn who is bald. Okay. And you also have a hypopigmented lesion which is there. So you have a dermatitis and you have scalp which is showing you sparse hair, and the blood gas is showing you severe metabolic acidosis. You are looking at is a particular disorder which has a therapeutic what you can say value, and if you give this Ramban Upay to this baby will survive lifelong. And what you have is a history of similar affection in the previous baby, and what you are dealing here with is a biotin deficiency. And have a look at this baby. There are two pathological signs which are visible in this 1 month-old baby. There is fast breathing, and the second thing that you should notice is there is loss of subcutaneous fat. Look at the loose skin folds. So there is failure to thrive. So what's your probable differential diagnosis? Again, you are having no chest in drawing. There is no grunt, and the baby is showing you very classically acidotic breathing. So acidotic breathing in a month-old could be because of infection, so sepsis, anemia. It could be renal failure. It could be a lactic acidosis secondary to inborn errors of metabolism. But the blood gas comes out with a decreased anion gap. So one of the few conditions, majority of the conditions with metabolic acidosis would come with increased anion gap. But this is one which comes to you with normal to decreased anion gap. What you are looking at is a baby who turned out to have renal tubular acidosis. But mark the acidosis, mark the failure to thrive, and then you can put 2 and 2 together. Okay, look at this baby having a 2-month-old who has this disconjugated eye movement, a squint for that matter. Physiological or pathological? Most of us assure the parents, yes, but don't assure them beyond 3 months of age. They must be looked after by ophthalmologist, simply because the causes of a squint beyond 3 months are very ominous, and they would turn out to be pathological. And once we had a baby with similar squint, but with asymmetry of the cornea, and it turned out to be a retinoblastoma. So the point is, do not assure parents if the squint persists beyond 3 months and you have this baby with a pathological thing. And obviously what you have here is a natal tooth. Don't intervene unless there is a risk of aspiration, and don't go by the size, go by the internal ring. If you have this umbilical hernia, which is beyond 5 centimeters of internal ring, most of them would not close, but you will still continue to follow up. And majority of the times, most of them would recover on their own. At times, this is probably the last slide, the diagnosis is based on what you hear. So this baby is grunting, but to my surprise, this was not a grunt because of lung pathology. Mind you, many a times you would have extra respiratory causes for grunt. The commonest is GI or CNS. So next time you hear a grunt, take that baby first in because they are all ominous, and look at this baby. The count here is 30,000. So it's unless you hear this cough, this cough is pertussoid in nature. It is not pertussis simply because there is no whoop. And these babies come again in epidemics. You have here again a clue on what you see and what you hear to come to a final diagnosis. So I think at this stage, I will stop for want of time. Thank you so much. The purpose here was to sensitize you to think and make the most of your clinical acumen. Thank you so much.
Thank you so much, sir. It was an excellent collection of pictures, and as they always say, pictorial memory is always better than what we actually read. I'm sure all the delegates agree to this, and they had a pictorial feast today. We have two questions, sir, in the chat box. Can I just ask that? Yeah. So there was
Please.
first question on the hemangioma slide. So if we have a forehead hemangioma, do we do an MRI to look for an intracranial extension?
No, simply because, again, if it's a congenital hemangioma, yes, there may be an intracranial extension. Most of the times what you and me are going to see are hemangiomas, which appear sometimes after first few days or weeks of life. They are all infantile hemangiomas.
Right.
Most of them are benign. So they don't have an intracranial extension.
Okay, all right, sir.
And therefore, it is important to always ask, is it a congenital lesion? Congenital lesions are not going to follow the rules of the game.
Right, sir. Right. And the second question was on that excellent picture of a congenital chikungunya. So we have a question. What do we actually mean by paradoxical cry in congenital
Okay.
chikungunya?
Not congenital chikungunya. What paradoxical cry means, normally a newborn, when you pick the baby, it will become quiet. This
Right.
is a baby who's going to cry a lot when you pick up. So what this baby is having is diffuse musculoskeletal inflammation. Or it could be, same is true with a baby with congenital syphilis. Same is true with a baby with osteomyelitis. You pick up the baby, instead of crying, being stopped, this baby would show you what is called as paradoxical cry. So always, when you examine, look at these subtle clues because they are pathognomic, which are giving you clearly, because otherwise you do a number of tests, unless you think about it, you will never hit the diagnosis.
Right, sir. So I think those were the two questions we had in the chat box. We can move ahead to our second speaker now. Our second session is by Dr. Ravi Ramadwar, sir. May I ask for the CV slide, please? Somebody from the office is there, Mahaip. Can we have the CV slide for sir? So sir has already joined. I would like to introduce sir. Sir is actually needs no introduction. Sir is a very senior consultant pediatric surgeon from Mumbai. Sir is attached to Hinduja, SRCC Children's Hospital, HN Reliance Hospital, Zain Hospital, and Breach Candy Hospital in Mumbai. And sir has plenty of publications to his credit, and he has demonstrated more than 125 operations in more than 80 laparoscopic and open surgery workshops in India and abroad. Over to you now, sir, for our second session on pictorial pediatrics.
Amrita, I'd just like to add that
Sure,
he is
sir.
There is a master laparoscopic surgeon. In
Laparoscope.
fact,
Absolutely, sir.
he's the teacher of teachers in laparoscopic surgery pediatrics, and I like a lot of adult laparoscopic surgeon I know would want to associate and sort of get work with him. That's one. Number two, he's a very great pediatric neurosurgeon. Besides the general surgeon, his specialty is also pediatric neurosurgery, and he's like he can remove a 1 kilo tumor through a laparoscope. I mean, that's what I would describe him
Yes.
as.
Yeah, we are really honored to have you on this session, sir. So our next session will be on
I know him
pictorial
because he's in
pediatrics.
Hinduja with me, so
I
I've seen him
know,
working so closely
I
for
know.
years. Yes.
So all of us in
Right.
Mumbai and all over, I think, know sir very well. So next session is on pictorial pediatric surgery. Over to you, sir.
Thank you very much for very kind introduction. And Nitin bhai, thanks a lot. Are you able to see my screen?
No, sir.
Not yet.
Oh, okay. What's happening? No, I've changed my laptop because my laptop conked a few days back.
Oh,
So I had to buy a new MacBook just for this meeting.
only
I'm kidding.
surgeons can afford to
I
buy a
am
Mac.
kidding. But I don't know what's happening here. It
You
doesn't
are
seem to
seeing
be.
the share screen green, that icon, or no?
I am, but it says that I need to leave meeting and again rejoin. I don't know why
Okay,
it
do
says
it,
that.
do it, do it, do it.
Yeah.
Do it. It can happen.
We'll just wait for sir
Amrita,
to
till the time
rejoin.
he can do it. Maybe I can just sum up the first one so that we don't
Sure,
waste
sir.
time.
Sure, sir.
Yeah,
Sure,
so
sir.
I think Rishikesh, you are an encyclopedia of neurology and the first few months of life. You showed some 18 different cases. I was noting on each one of them. And I would just want to say for the quick recap, as Ram asked me to do, is that number one, never forget to do cord TSH. And if you haven't done cord TSH, don't do it in the first 40 hours because of stress of birth. Do it at the end of 5 or 7 days. In a preterm, the rules are different. When it comes to hemangioma, if it's congenital, never give a good prognosis that it's going to resolve on its own. Whereas the ones which come a little later are likely to disappear by second or third year. You can use timolol, you can use steroid, propranolol. I mean, there are multiple ways of treating it. The pre-orbicular tag, I think very important message was they do not subject them, all of them, to renal ultrasound or scare them because it's not really required. But what is important is to do in OAE for hearing screening. That's important. The jaundice in newborn, never miss pale stools, especially because these cholestatic jaundice come in second or third week. And if you miss on the correct timing of picking them early, then the Kasai surgery outcome may not be as good as beyond 6 to 8 weeks. So you need to do quickly and always look at this. And there are color strips available to compare stool color with the those strip and see which are the actual pale and which are not actual pale. Then coming to the pilonidal sinus, and I think that's an important message that you see pilonidal sinus so many times. If it is beyond 2.5 centimeters from the anal verge, it is likely to have a tethered cord or some other anomaly beyond. Especially also there is a tuft of hair. So all pilonidal sinus are not benign, and they must be subjected to imaging, ultrasound, little MRI later. Otherwise, we have seen children being missed, and they come very late with paraparesis and actually a pilonidal sinus with a tethered cord was missed. A word about the DAOM, the depressor angulus oris muscle absence, very easy to differentiate it from seventh nerve palsy because it's isolated. Only when the child cries, you can see one side doesn't move. And though it's actually benign, but there might be associated anomalies. So you need to do a 2D echo and look at the urogenital issues. Blueberry muffin, very near to my heart because many of these blueberry muffins are actually neuroblastomas, acute myeloid leukemias, or one of those. But the common other condition which a pediatrician would see as coming with blueberry muffin is when they were late hemorrhagic disease of newborn, and those small cutaneous ecchymosis actually look like a blueberry muffin. So that's something which you should not miss. In chikungunya, paradoxical cry, very clearly, I still remember whether Parmanand is still there in the crowd, but I went once for some meeting at Thane, Jupiter, and he showed me a child of congenital chikungunya. We was exactly being the same way as what Dr. Rishikesh showed us. Alopecia and those white patches, don't miss biotin deficiency, something which is so easily treatable if you pick them in time. And I think the last two message I have is that when you have a baby with squint or without even squint, put a torch on the child's eye. And if you see a white reflux, then you know there is something which is not reflecting as good, and think that there could be an associated retinoblastoma, because if you pick them early, in early stage, then you know the outcome is excellent as compared if you miss them and patients come with very late stage of retinoblastoma. And we see this often in our day-to-day practice when I practice oncology. And lastly, the umbilical hernia, parents are very, very worried. We should not be worried about the size. And something like don't tie coins, don't try to put putty on that. It's not going to go that easily. Only you may obstruct it by haphazard bandaging. So just leave it alone. Tell the parent that probably it will disappear after some time. And if by, I mean, Ravi will throw some more light on umbilical hernias, but what I understand that by second year of life, they have not disappeared. And if they are large, then maybe they should be subjected to surgery. So that is what I have to say about the first presentation. Now I think Ravi has joined. So Ravi, over to
Yes.
you.
Thank you so much, sir. So that was a very quick recap. All the pictures are now reinforced better. Yeah, that was an excellent recap. Over to you,
Thank you.
Dr. Ravi Ramadwar, sir, now for our next presentation.
Yeah, thank you very much for kind invite. Are you able to see my screen now? Is it in a slideshow
Yes,
Yeah, put
format?
it full
Yes.
screen. Put it full screen.
Yeah, I'm just working on that front. There seems to be some issue here. Okay, got it?
No, it's still not showing full screen.
Sir, you have to click on the slideshow.
I have clicked on the slideshow, but I don't know what's happening. Sorry, it's not generally like this. It doesn't happen like this, but it's all right. We'll work on that. But you're able to see my slides, no? So it's all
Yeah,
right.
it's okay. You continue. It's okay. Yeah.
Yeah. So at the outset, let me thank everybody for inviting me for this interesting session on pictorial pediatrics. This is the first time I'm actually participating in such a kind of session. So it's a learning process for me. So if I make many mistakes, I apologize at the outset. Thank you, Nitin Shah sir, Sushma, everybody from Maharashtra IP and Central IP to give me opportunity to share some of my experiences. Sometimes what happens is we have been kind of looking after these patients. Like I've been practicing in pediatric service in the last 34 years and operated more than 1.5 lakh patients. Most of them, almost 60 to 70% would be complex surgeries. And we still get these very, very interesting patients coming up into our OPDs and we operate on them. So at the outset, I would like to thank all my patients for giving me opportunity to treat them, to their parents, to the referring doctors, to my anesthesia team, to the OT team, and everybody else who is involved in care of children. I think we all owe a big thank you to them. So can anybody tell me what is this? Anybody in the chat? Can somebody write? Okay, I think we'll not go for question answer session. So this is a small lesion noticed immediately after birth, which was picked up antenatal, and everybody thought this is probably a omphalocele coming out of the nostril. But the interesting thing was, as the child would breathe, this thing would just flutter as if it's a flower in the wind. And it was a very interesting sight. And unfortunately, I don't have the video, but you could see the different orientation of this. When the child is on one side, it goes on to the medial side. When you put him on a lateral position, it goes on the lateral side. So this was a fibroepithelial polyp arising from the nasal septum, something which probably an extremely rare scenario, but something which I managed to see. So that is something which is an interesting thing. Now, one very common problem, I'll cover just two common problems and then get on with more interesting stuff since we are dealing with mostly neonatal work. So bilateral undescended testes, which are not palpable, something to start worrying about from day one. Do not ignore this patient for years together saying that the testes will descend on themselves. They need investigation. The basic minimum investigation in neonatal age would be a sonography to identify if there is testes or not and what are the internal genitalia like. This patient has got a nice well-developed penis, so most probably there is no chromosomal anomaly, but if there is an associated hypospadias, one has to look for any ambiguous genitalia issues, need to do all the hormonal work, chromosomal studies, and the entire paraphernalia. Now, luckily, this child had intra-abdominal testes. Now, one of the things which we need to do is, I think I'm struggling a bit today, is we put a laparoscope in patients in whom we don't have a palpable testes. And there is a reason for that. The reason for that is we have seen many sonographies, MRI, CTs being done on these children, which doesn't show anything. and we put a laparoscope, we find a blind ending vas with a lymph node sitting next to it, sometimes reported as undescended intra-abdominal testes. Sometimes you see the testes here, and sometimes you see the testes near the kidney or above the kidney. I've seen one above the spleen also. So it's very, very interesting anatomy which you can see, and this will never be picked up on sonography, on CT or on MR or anything else. So the diagnostic laparoscopy remains a very important tool for these patients. Now, we tend to operate these patients around the age of 6 to 8 months and bring them down in single stage. As you can see here, both testes have been brought down. I will not go into surgical details. Another common condition is hypospadias, as you can see it here. Very common. The incidence is supposed to be 1 in 300 to 400 male live-born babies. It's a common condition. Many times, almost a third of these patients will have associated renal anomaly. So make sure that you do an ultrasound to rule out any associated complex renal malformations, which may require surgery or treatment right in the beginning in neonatal age. Otherwise, this patient would be operated somewhere between 8 months to 1 year of age before they start walking, because it's very easy to manage catheters and tubes before they start walking. Now, what was this? Now, this was something fascinating. This was a child who, this was antenatally diagnosed, some sort of a mass in the abdomen, and it was not very sure what it was. We could see the kidneys, we could see the adrenals, we could see the liver, we could see the lung, and nobody knew what we were dealing with. So this is a fetal MRI. You can see the uterus, you can see the amniotic fluid, you can see the lung, you can see the heart, you can see the vessels, you can see the liver, see the portal structures, see the GI tract, see the kidney, and there is this big mass sitting here under the diaphragm. So one always thought that this is possibly a teratoma rather than anything else, but the story goes on. So the pregnancy was continued because this was told to the parents that best to terminate because we don't know what it is. And we all decided after a healthy, long discussion and multiple discussion that this is something we need to continue because this is a treatable scenario. Rest of the conditions are absolutely normal. There was amniotic karyotyping was also done, which was fine. So this baby was born, and this was the CT done, I think on day 3 or day 4. You can see a very large lesion sitting here with some calcification, and you can see the normal liver, normal spleen. The GI tract was absolutely normal. The child was on feed and was tolerating feeds properly. So again, the differential came as, are we dealing with a teratoma? Are we dealing with neuroblastoma? Are we dealing with some ganglioneuroma or some funny thing? Because there was so much of issue that was involved, finally, none of the investigation could tell us what it was, and we were reluctant to do an FNAC. Anyway, whatever it was needed to be removed because of fairly large lesion. So we went in, and this is how we found the lesion. The stomach was separate, the spleen was separate, and there was a massive lesion sitting under the diaphragm with a nice blood supply coming from the aorta. And what it turned out to be is something which is really fascinating. It turned out to be intra-abdominal lung sequestration. So as I said, despite spending 34 years, we keep on getting these fascinating cases coming to us, throwing us completely in an unknown area, and we don't know how to deal with them many times. So we always have a group discussion, discuss with colleagues, discuss with all the specialists concerned, and then decide what should be the best option for these patients and how to go about it. And that is something which I would like to say, that it is very important to have a teamwork whenever you deal with something complex. And it is always beneficial for the patients. Now, can somebody tell me what this is? Just watch this video. So this is a 3-week-old baby, multiple episodes of vomiting.
CHPS.
Perfect. It's a very spot diagnosis. But the fact that we have reached this stage means we have probably late in diagnosis and picking up CHPS. This should have been picked up on sonography. Instead, what was done was a contrast
Sir,
study.
sorry to interrupt, sir. Can you please press the play button on the top of your screen? Maybe that leads to the full screen view. Because you have to change the slide every time.
So it doesn't give me the option of play.
No, there is. It's on your screen.
We can see the play button on your
There is a
screen.
play button on your screen, sir.
Where?
After between add slide and table.
Oh, I can't see that. Hang on, 1 minute. Because your Zoom thing comes in front now, so I can't see. So let me just minimize this.
Yes, that one, sir.
Yeah, but again, it's not allowing me to. There
Yes,
you
sir.
are. Very well.
Yes.
Thank
Sir.
you.
Now it's full screen, sir.
Thank you. Yes. Technological hiccups. So this child came to us with a barium study. Why would you do a barium? This is something I deliberately wanted to show, that please don't do barium studies because it's very painful to wash out this barium. It takes at least 3 to 4 days of at least multiple washouts every single day to clear out this barium, because when we operate on these patients, in case there is a mucosal breach, the barium goes into the peritoneal cavity, and that will induce significant chemical peritonitis. And that is something which we want to avoid, because we have seen patients who come with dense adhesive obstructions and you just can't operate on them. So please avoid using barium. Use, if at all you have to use a water soluble contrast. Now this is the operative finding of that patient. So you can see in the slide on the left side, nice pyloric tumor sitting there, and my arrow doesn't come up. And we do a pyloromyotomy, and you can see that pylorus is nicely opened out. So this is the treatment. Whether you do it open or laparoscopic doesn't matter, but this is the treatment. I'm going to show you some intraoperative images because I'm sure pediatricians don't get to see them many times. So it's something I thought maybe it might be interesting. Now this is a 1.8 kg 34-week baby, started on feeds on day 3, thinking that everything is okay, and developed sudden abdominal distension by evening. So you can see, in fact, the markings on the abdomen because of the diaper. And this was the X-ray. The X-ray shows a massive amount of air inside the peritoneal cavity. You can see a lateral X-ray showing a big gaseous bubble under the abdominal wall. So this is something very, very important. If in a supine position you are not able to appreciate free air in the abdomen, take a lateral shoot through, and you'll be able to see the air under the abdominal wall and pushing the liver and the intestine down, which you can see here beautifully. So that is something which one should consider, and that is a useful tip. So this patient we explored had NEC, localized NEC with perforation. We resected that area and everything settled down, and patient was discharged later. Spot diagnosis? It's an imperforate anus. You can't see anal opening. So if you see such a patient, you need to investigate for everything else, like what was mentioned, that if you see a TO fistula, you need to look for spinal anomalies, rib anomalies, limb anomalies, renal anomalies. Anorectal anomalies also form a very, very important part in it. So it's a vectoral group of anomalies. So this is an anomaly where you can see that there is some sort of a skin fold over there. So what we did was we put a small probe, and we could see that the probe goes in and there was a meconial staining, indicating that this is a low anomaly. Low anomalies in boys is much uncommon. Intermediate and high anomalies are far more common in boys. So remember something, that unless there is a specific indication, there should not be any local exploration without proper investigations. What is a proper investigation? Like in this patient, because it was a low anomaly, this is what we did, was an anoplasty. We opened it out, made a wide anal opening, the sphincters were well saved, and this is a functional anus. Most of the low anomaly patients will have constipation because of prolonged rectal dilatation, and they may require dietary management and laxatives. Now this is a girl child. This is a girl child with imperforate anus. So in a girl child, normally you would have a urethral opening, you would have a vaginal orifice, and you will have an anal opening. So you should see 3 openings. If you don't see 3 openings, you need to start worrying that what is it? What are we dealing with? Here you can see that there are only 2 openings that are visible. Sometimes there is only 1 opening. So 1 opening means cloaca, very serious anomaly, need to be dealt with immediately. A lot of investigation, a lot of complex problems, and long-term issues in patients with cloacas. So that is something which one needs to be very, very clear about and needs to act on it. Now in girls, the commonest anomaly is a vestibular fistula, accounting for 90% of anorectal malformations. And with vestibular fistula, whether it is an anovestibular or a rectovestibular, they will start passing meconium from the vaginal introitus. The opening is just behind the vaginal introitus, actually, in the vestibule of the vagina. And from there, they will pass meconium. So they may not be obstructed on day 1. You may see a diaper which is meconium stained. You will say there is no problem. There is no imperfect anus. But please check the anal opening. These patients come many times at a later age. I have had a patient of 29 years of age investigated for infertility, who actually had an anovestibular fistula. So please look that there are three openings in the perineum: a urethral opening, the vaginal opening, as well as the anorectal opening. Confirm that the child is passing from the rectal opening or anal opening and not from the vestibule or from the cloacal opening, because 99% of girls would pass meconium through one of these openings. So your diagnosis can be misplaced, and we have had patients who come on day 5, day 6 with a rectal atresia with no fistula coming on day 5 with a sigmoid colon perforation or a rectal perforation. So this is a simple examination which every single pediatrician neonatologist attending babies must do. Again, very common scenario in boys is an imperfect anus, as you can see from here. And as I said, 90% of them would be intermediate or high anomalies. So they would need something which is called as a prone shoot through or a invertogram. We don't do invertogram these days. We do prone shoot through, which is done in a lying down position, pushing, keeping a big bolster under the pelvis so that the rectum and the anal opening becomes the highest point of the perineum. You don't need to put a marker, which is put here. And then we tend to take a lateral X-ray like we did for the perforation. We take a lateral X-ray to look for the level of gas, where exactly it is going based on some anatomical landmarks related to the bones. So then we divide them into intermediate, high, and low anomalies. Now in this patient, you can see the gas going well beyond the ischial bone. But this is actually an intermediate anomaly because this patient turned out to have a rectourethral fistula. So invertogram is not a foolproof method of knowing whether it is low or intermediate anomaly. Sometimes you can make a mistake. Like in this patient, anoplasty was done and the patient came back with UTI. So something that can genuinely happen. So sometimes it is probably easier to err towards doing a colostomy rather than trying to do a perineal procedure. So that is something which one needs to be careful about. Generally, this is the kind of colostomy that is done, and these kind of colostomy will have this ring which is kept for about 5 to 7 days to make sure that the colon gets properly adherent and does not retract. But the preferred colostomy is something like this, where the proximal opening is bigger and the distal opening is tiny, so that there is no fecal contamination of the distal part. You wash out the entire anorectal area at the time of colostomy and prevent contamination of the distal part. So this patient will require a contrast study, and you may see some X-ray like this, and you may think that there is something over here, but there is actually the dye is going from the colostomy into the rectum, and there is a fistulous connection with the urethra and coming out to the penis. So this shows that this child actually had a rectourethral fistula. So this is the workup which needs to be done, and that is something which the pediatric surgeon would do. We already had a discussion of esophageal atresia, TO fistula, so I'm not going to bore you out with it, but we tend to do them thoracoscopically. For the last 20 years, we have been doing them with very good results. These are the contrast studies which are done on post-op to show that there is normal esophagus. I want to talk something about this anomaly because this is something which we have been working on for the last 20 plus years. This is a pure esophageal atresia without fistula, where a large segment of the esophagus is missing. A lot of these patients would have an esophagostomy and a feeding gastrostomy, and then would have an esophageal replacement in the form of either colon or a stomach or a gastric tube. So I was one of the first few people in the world to start laparoscopic transhiatal gastric pull-up as an esophageal replacement for these patients, but it has got its own problems. So we have come up with a very interesting way of dealing with this problem. And the way we deal with it, we make the esophagus grow. So we grow the esophagus, which is only up to the neck. We grow it up to T6, T7, T8 level in multiple stages. And as you can see from images, you can see the esophagus has really grown significant amount. And then we go in and anastomose the esophagus to a very small tube coming from to the stomach. This helps in preserving the esophagus. It helps in preserving the gastric capacity. It minimizes the chances of leakage, stricture formation. As you can see from the post-op contrast study, it's a nice, beautiful looking esophagus, and the GI tract is properly accessible by endoscopy forever. So this is something which we have started working since last 7-8 years, and it is giving very good results. So this is something which I want all the pediatricians as well as anybody else who is involved in looking after these babies to be aware that this is a very good option for our scenario, where post-operative care of esophageal replacement is really painful. They have lots and lots of issues and lots of complications. So this is something which is important to remember, that we can grow the esophagus, we can grow a variety of organs. A child with bilious vomiting, particularly newborn or an infant, one must do a contrast study, and this is what you will see. You see the contrast into the stomach, you see the contrast going to the first and second part of duodenum, but you don't see the third and fourth part of duodenum. You don't see the C loop of the duodenum, you see the jejunal loops on the right side. So this is a malrotation. Malrotation is an impending emergency. If the child is not in shock, the child can go in shock at any point of time because of malrotation, volvulus, and complete gut infarction, extending from DJ flexure to mid-transverse colon, because that is what midgut is. And once you lose that midgut because of ischemia, you will not be able to save these children. So very important to diagnose malrotation, have a very high index of suspicion, and treat them as early as possible. In whatever center is closest to you, they should be treated. But remember, if they are going in shock and have bilious vomiting with a scaphoid abdomen, that is a very, very rapid emergency. That is something which is life-threatening and needs to be immediately taken care of. Spot diagnosis, exomphalos, generally picked up antenatally. Many times they are terminated. But this is a baby who came from Singapore because they wanted to maintain the pregnancy. It was a precious pregnancy and large exomphalos. So we did an X-ray on the child, and child also had a kyphoscoliosis. So remember, there will be complex anomalies. This child also had a hypoplastic right ventricle. So they were wondering whether there is a cardiac anomaly also. And there was absence of the 12th rib on the left side. You can see that there is hardly any space in the abdomen on the left side. Everything is outside. So this is not something which we can treat conservatively, allow the eschar to form, and then do surgery at a later stage. So we went in with a silo formation. The silo was created using bio surface meshes, and the silo reduction was gradually done. And after about 3 weeks, this is how the closure was there. Now, once the exomphalos was repaired and the closure was achieved, the right hypoplastic ventricle became a normal ventricle. So the reason was probably the kinking of the IVC, the compression of the exomphalos because of the hypoplastic left abdominal wall, that we ended up with a compression of the right ventricle diagnosed as a hypoplastic right ventricle. This is how the long-term follow-up is. They keep coming every year. This is another interesting one. Again, precious pregnancy, antenatal diagnosed, big cystic mass in the abdomen. We don't know what it was. As soon as the baby was born, baby had severe respiratory distress. You can see massively distended abdomen with dilated vessels. So within 1 hour of baby being born, we arranged for blood and everything and opened up this patient in Bridge Candy. And we could see that there was 350 ml of fluid inside a large cystic space, which was adherent to everything, right from the liver, diaphragm, spleen, stomach, intestine, colon, to the uterus, to the ovaries, everything, whatever was there, it was taking blood supply from all these structures. And on further exploration, we could find that there was a atresia and a perforation from the atretic end into this dilated cystic mass, suggestive of meconium peritonitis with a giant meconium cyst. So this child underwent an ileostomy and then anastomosis of the ileum. Another common problem which you see is an antenatally diagnosed hydronephrosis. I don't have time enough to go into great details of hydronephrosis. And I think probably I'm finishing my talking time, isn't it? Can I have a few more minutes? Is that okay?
Yes, sir. Yes, sir. Definitely.
So as you can see that this is a very gross hydronephrosis. There is a parenchymal thinning and the urinary bladder is showing mild wall thickening. In this scenario, one needs to do an MCU because one needs to rule out PU valves. And this is what an MCU was done. And you could see the crenated bladder, but there are no valves. There is no reflux. So we did a EC scan on this child and you could see a completely obstructed system. Now the question was, it's a hydronephrosis. Do we really need to operate a 3-week-old baby because of hydronephrosis? But the decision to operate is based on this. It's a huge, large palpable mass. So large palpable hydronephrotic masses need to be operated. That is one of the indications of treatment for hydronephrosis even in neonates and infants. You can see how large it was. So we went in by laparoscopic, retroperitoneoscopically, that is from behind. We did the laparoscopic pyeloplasty, inserted a stent, and the stent position was confirmed at the end of surgery by C-arm image. This is something what you can get for antenatal diagnosed hydronephrosis. A PU valve with bilateral gross hydroureteral nephrosis because of reflux. So these are the patients who will require a cystoscopy, fulguration of their valves, further assessment of their bladder, assessment of their renal parameters, growth and development, and a long-term follow-up by pediatric nephroteam. That is what is being done by Pankaj at this point of time. Child with jaundice or antenatally diagnosed cystic mass in the abdomen. Sonography shows a choledochal cyst. You do an MRCP. You identify a large dilated common bile duct dilated intrahepatic biliary system. So this is a choledochal cyst. If there is no infection, active infection, we would go in laparoscopically, excise it, and do a enteral anastomosis after excising the gallbladder and the biliary tree. But the important thing to remember that the pancreatic duct needs to be taken care of. But at the same time, if it is a 3-week-old baby or a 4-week-old baby, don't sit on it. Don't keep on giving phenobarb and doing HIDA scans and everything else. If the sonography does not show you gallbladder, does not show you bile ducts, it is probably biliary atresia. Like this child came almost at the age of 8 weeks. You could see already the capillaries are dilated on the liver surface. There is no gallbladder that is visible. So we opened this patient. It was a classic biliary atresia. We did a portoenterostomy, deep portal dissection. We could see the yellow staining on the Gospi. So there was some bile drainage. We did a portoenterostomy, and the child bilirubin came down to near normal in a span of about 2 months. Large abdominal distension, one needs to palpate the abdomen. Don't just ask for sonography. Now, on palpation, you would find that there is something more to it. And in fact, this was a large palpable mass in the right side of the abdomen. Will need investigation or sonography, and a CT scan shows a massive tumor arising from the right kidney. Would require biopsy, chemotherapy, depending on the staging based on the investigations, and then excision of the tumor. Now, this tumor was on the CT scan had almost ruptured into the perinephric space. So we went in after 48 hours and we excised the tumor without spillage, and then the child went on for post-op chemotherapy. So this is something which we keep on saying. Now, this is a very, very interesting scenario. Pectus excavatum following a cardiac surgery in neonatal age. The sternum got stuck to the heart and did not allow the sternum to grow, causing respiratory insufficiency, which was proven on VQ scans, on spirometry, and a variety of investigations by pulmonologists. So finally, a decision came that we need to operate, and we did a CT. On the CT, you could see the sternum was actually pushing into the heart. It was densely adherent, so we needed to release it from the sternum, redo sternotomy, release the entire sternum from the heart, then do a Ravish procedure where we actually excise the cartilages of the lower 6 ribs and fracture the manubrium sternum, put up plates, and then do the closure. So this is something was done for this child. So a lot of complex things we see. We do have a combined team effort for these managing these kind of patients, and this is something which gives us a pleasure working in different hospitals and institute, having people like Dr. Nitin Shah and the other people in different hospitals. So with this, I will stop. Thank you very much for your kind attention. I'm okay to answer any questions if you have.
Thank you so much, sir. That was a wonderful session with some amazing pictures. It almost felt like we were attending a surgical OSCE. And thank you for so many intraoperative images. As sir rightly said, as pediatricians, we actually don't know what lies beneath. So yes, sir, we do have one or two questions. First question was in exomphalus causing hypoplastic right ventricle. So can you explain that a bit?
Yeah, so the cardiologists were involved in managing this patient. Dr. Bharat Dalvi was involved, and he thought that it is a hypoplastic right ventricle. Even on antenatal scans, it was apparent as if it's the right ventricle was just not filling up.
Right.
So when I operated on this child, because of the hypoplastic left abdomen, you could see that there was, because of scoliosis, there was hardly any space in the left side of abdomen. So the entire organs were onto the left side, kinking the IVC. And because of that, possibly the diaphragm was also kinked. So when I operated on this patient, the IVC and the liver was densely plastered to the entire diaphragm. So I needed to release it down, bring it down completely. And then once the diaphragm was free and we created a silo, there was no pressure on the diaphragm, and then diaphragm came down. On the subsequent X-ray, I didn't have enough time to show all the series of X-rays.
Right.
And because the diaphragm could come down, there was enough space for the ventricle probably to fill up. That's what we thought. Okay. Annual echo is not showing anything dysfunctional on the right ventricle. So Dr. Bharat Dalvi also felt that this is just because of the anatomical aberration of the exomphalos, kinking, and lack of space because of scoliosis, hypoplastic abdominal wall, variety of other associated issues, that we had this impression of hypoplastic ventricle, but actually it was not a hypoplastic ventricle.
Right, sir, right. And sir, there was another question on how does the esophagus grow. I think the question was meant for the esophageal atresia case.
Yeah.
So we could just share something about the esophageal replacement.
Yeah. So this is a very, very useful and an important question actually. Now, I'm sure you all must have seen orthopedic surgeons for years together. They have been using a technique to grow the limbs, to grow the fractured bones. Now, when they grow the limbs or grow the fracture bones, they not only grow the bone, they also grow the muscles, they grow the skin, they grow the fascia, they grow the vessels, they grow the tendons, they grow the nerves, the cutaneous nerve, the motor nerves, everything grows. So that tells us that gradual distraction of tissues will allow histogenesis to happen. Now, the histogenesis will happen much more easily in neonates and infants because they are in a rapid growth phase. So that is the time if you do this distraction induced histogenesis, the organs will grow. In fact, how it started was the Western centers have started doing this primarily. So by what they would do is they will either open the chest or do thoracoscopy, put a suture on the ends of the esophagus and gradually start pulling them every other day. And then they would have disruption of the sutures, breakage of the esophagus, perforation, ischemia, stricture formation. But if you give adequate time for that esophagus to settle down in a new environment in the subacute plane, the esophagus actually grows very beautifully.
Okay.
And in fact, the blood supply is so robust that we actually thought when we are doing the anastomosis that whether we'll need to give blood transfusion because the way the blood supply was there. So it's an amazing way of dealing with the problem. And in our country, I think this is one of the ways to solve complications of esophageal replacements and minimize the mortality as well as probably have zero morbidity in these patients.
Right, sir. That is beautifully explained, sir. So it was indeed a privilege to listen to you today. And it was more than an excellent talk. I would request Dr. Nitin Shah, sir, to give the crisp take-home messages as the rapid fire
Okay,
again.
so okay, Amrita, thank you. So I think again, the second speaker, Dr. Ravi, my friend, showed around 18 to 19 different scenarios in pediatric surgery. Some of them were intra pictures as well as X-rays and the technique, which was of course something which is great. But I think the take-home message for the pediatrician is that number one, when you examine a newborn, you strip the child, look at the testes in a boy. Cryptorchidism cannot be missed, especially bilateral. That can be really troublesome. We have had the children coming at 10 and 12 years with one side testis missing. And Ravi will say that even a surgeon of some 30 years had not known that his testis is missing. So I think that is something which is our fault. The second thing is also look at the penis and look at hypospadias. Higher the hypospadias, there may be chance that it's not only it's a hypospadias, but a case of DSD, the sexual the disorder of sexual differentiation. So keep that in mind. Something which I first time heard is a fetal MRI, and that picture was so beautiful, showing all the organs. I think that is something which is done very easily, and now we have fetal medicine as a branch itself. When you examine a newborn, don't forget to do the orifice count. So in a female, 3 orifices, in male, 2 orifices. And not only that, but also look at the upper orifice of esophagus, pass in a RT, see that it goes well, and you push in a syringe bubble and auscultate that you can hear the bubble in the stomach. That will rule out a TO fistula except H-shape. And H-shape fistula can be really troublesome sometimes. Can come with respiratory infection, asthma-like picture, and a good imaging and a bronchoscopy can actually pick it up very easily. Malrotation is not an emergency because the patient can die of shock, but also because if you don't operate in time, then you may lose the intestine. And if a child loses a lot of length of intestine, he can have a lot of confusion about malabsorption, iron malabsorption, B12 malabsorption, and so on and so forth. So, and the last but not the least, the cross between the first speaker and the second speaker was when you see a child with pale stool, as I said, especially second, third week, pick them up early, and an ultrasound shows the treatable cause like colitis cyst, then you know that child is really cured of his problem. And even if it is biliary atresia, earlier you operate, better it is as far as the CASA is outcome. So you allow the child to grow well. Ultimately, CASA is the bridge to ultimate transplant. Very few children will live without transplant, but if you have done CASA is well in time, then they will grow very well, and by 10, 12 years maybe you will be able to do a liver transplant. And besides that, he showed a lot of masses, abdominal masses, hernias, etc., which are of course very important. These are the important message that I had from Dr. Ravish talk. Thank you. And I hope
Thank you, Nitin Shah, sir.
I hope
Thank you, sir.
no. So 1 minute. So I hope all those 250 plus people who had joined, they had joined not only to get the one MMC point, but also to gain excellent knowledge from both the speakers. Both the neurologist and the surgeon really gave some insight into massive thing, which I think we can learn even at the age of 60s and 70s, like how I'm learning today. Thank you.
Thank you, Nitin sir, for honoring my request.
Thank you, sir. Thank you, Nitin sir. That was indeed very crisp and to the point as always. And I thank both the speakers. They did an excellent job today. I'm sure all of us have some really good pictorial memory today, thanks to the experts. And that's going to help us in our clinical practice. I will now request Dr. Praveen Gokhale, sir, Vice President Maha IAP and President of Thane Academy of Pediatrics, to kindly give a vote of thanks.
Thanks, Amruta. I think today's session was really very excellent, which everyone has enjoyed. Pictorial Pediatrics was devised to let us understand what we have not seen, and we should keep in mind what we have not seen, and then that will help us in future to detect these conditions. I thank all the central IIP dignitaries who were present for today's program, especially Dr. Basavaraj, Dr. Parmanand Andadkar, Dr. Nitin Shah, who summed up entire two talks very succinctly by his excellent clinical knowledge. And I finally want to thank Amruta Shirodkar for conducting this session very efficiently. With this, I think we will take a lot of take-home messages and remember whenever the next case is present in a similar way. Thanks to everyone. And with this, I conclude the program.
Thank you, everyone. Good night.